Hey everybody, welcome to this evening's Fertility Live with myself and Dr Anthony Marren. I'll just wait a couple of minutes for everybody to just come in and join. It's always the little wait of people to kind of jump in. Hi, thank you for joining. Hey Beck, thanks for joining guys. Sorry that we weren't here last week, illness, Sydney winter, feels like everybody's sick, but we're all back and hopefully, it's going to be sunny at some point soon and the rain is going away. So thanks guys for joining and thank you always for loading up your questions as well. So while people are just jumping in, I'm just going to introduce Dr. Anthony Marren to you guys. Dr. Marren is an amazing fertility specialist. We're actually doing a live today. So you've got both of us on the one screen, which is great. So Dr. Marren works for Genea in Sydney. His room's in Kent Street and also in St Leonard's, which is where we are at the moment with his beautiful artwork behind. So Dr. Marren is a really skilled laparoscopic surgeon. He's got special interests in endometriosis, recurrent implantation failure. He's doing some really interesting research on immune issues and implantation failure. And he is also at RPA. Yes, good. Just wanted to check which hospital it was. So he is also there in the public system as well as at Genea. So we're really excited for him to join us and very much grateful. Thank you very much for giving up your Wednesday evening with your family.
Thank you for asking me.
Pleasure. So thank you. So look, what I thought we'd do is we've got heaps of questions that people have, popped in there. But, so one of your, special interest areas, whatever, is in surgery, would you say? And one of your skill sets, laparoscopy, hysteroscopy.
Yes.
How do you identify, or who are the people that really should be considering that in their fertility journey?
So I suppose a couple of things. So things like endometriosis is relatively common. So it's present in 10% of all women, and it's present in up to about 50% of women with unexplained infertility. And it's also present in about 50% of women with classic pain symptoms who present to a gynecologist. So obviously, when we sort of see couples, we take a thorough history from both. Mm-hmm. And so people have the classic pain symptoms, pain with periods, pain with intercourse, things like that, then that will sort of guide you down that path.
Because period pain is not normal, right? Many women have not painful periods.
Correct.
But so many women don't know that pain isn't normal.
Correct, yes, that's it, yeah. So, and so a lot of the history is quite focused in terms of trying to get as much information about their symptoms as possible. So there'll be some people where we get a bit of an inkling from their history. There'll be other people where the ultrasound will give the clue away, there might be endometrioma on an ultrasound.
But that's quite common though, would you say, not to see it on ultrasound?
Correct.
So I get a lot of women that come in saying, no, I don't have endometriosis, I've been checked, I've done an ultrasound. And I always say, was it a deep infiltrating ultrasound or just a normal ultrasound? Normal ultrasound, that doesn't mean you don't have it, right?
And I think it's also where the ultrasound is done is actually critically important as well.
Yeah.
And then I suppose the other thing is that, as I said, there's a huge proportion of people with unexplained infertility where endometriosis is an option or a possibility. And I suppose it's about exploring that. And it's not necessarily sort of saying that you should or shouldn't have a laparoscopy, but it's about talking about the role of it. And then I think
timing, I guess,
correct,
too, right? Yeah.
And then I suppose the other big thing is that obviously people are going through IVF, and what I will always say to my patients is that yes, IVF is a treatment, and we want people to fall pregnant, but in some ways it's also a bit of a diagnostic test. So, we see the eggs, we see the sperm, we see how the embryos come together, and embryo development to sort of day 3 is really all about the quality of the eggs.
Yep. From
day 3 to 5, it's about the sperm. So if you see someone who has done lots of IVF elsewhere and their embryo development early on is poor, then that will, even if there's an absence of pain in a normal scan, you'll often say, well, before you do anything else, you should have a laparoscopy.
Consider, absolutely. Yeah. And do you find too, sometimes women with a lower than expected AMH for their age, that's often endometriosis. Correct. Do you pay much attention to the CA125 blood test? I mean, as an adding into the tool?
No, so not really. So I think if someone's got something on an ovary, I'll do it just to make sure that we're happy it's a benign cyst. But if someone's got a normal CA125, I wouldn't
You would.
discount it.
Yes, yeah, okay, so yeah, so normal, high might mean something, but normal, that's what I say to people when it's normal. Like, well, it doesn't really mean anything, but we did it because, it's, and what would you say, do you think, like, I always make up numbers, so make them up. Everyone knows that, sorry guys. Like the percentage or the approximate amount of people who, I see a large portion of people, not large, but who have what I would call silent endometriosis. Yes. They're like, almost no symptoms, but like those things, maybe lower AMH, poorer egg quality, that's still worth investigating after a certain amount of failed cycles.
As I said, like I think at the end of each, at the end of each cycle, like I have a conversation with my patients. Yeah. And so obviously if someone's pregnant, then that's great. That's easy.
It's a nice conversation.
Yeah, that's right. But the ones who aren't, it's about trying to sort of say, well, this is what went well in the cycle, this didn't go well, and this is where we think we should go. So, even if someone's just done one cycle, if they're young and embryo development is poor on day 3, I would probably say I would do a laparoscopy at this point. Whereas if someone's done really, really, they've got lots of nice embryos and things like that, then you'd probably sit there and say, well, let's park it there as a possibility, but I wouldn't necessarily go down there now.
Rush into it now, And so for those of you who are like going, hang on a second, what? He sees me at the end of each cycle to have a discussion about what went right and what went wrong. No, you didn't hear that incorrectly. It is one of the probably biggest feedbacks that I get from shed patients that see Dr. Marren, is that he does actually have that conversation with you at the end. And you may not know this, but many people just get called by the nurses, it didn't work, let's go again kind of thing. And, I see people who say, I maybe suggest they look at, speaking to somebody about laparoscopy and endometriosis with symptoms who've done 4 or 5 cycles and not checked in. No.
Look, I think it's a bit sad if people don't have that sort of follow-up. Essentially, when I do an embryo transfer, I basically sort of say to the patients, your pregnancy test is going to be in 11 days, because that's when it is. And so I email my nurses, I email my secretary, and the blood test is done, phone chat's booked.
And that's really interesting about the, I often sort of talk about that, the sort of the egg quality being up to kind of day 3 and then more. I mean, obviously it's not an exact 50-50 sort of thing, but 3 to 5. Because I had a couple recently who gone through everything, older age, and ended up with donor, and didn't get much at the end from the 8, but like most of the drop off was that after day 3.
Yes.
But that's where sperm really needs to be looked at as well, right? Because I think often when women are older, it's like, oh, they're older. And then everything else kind of gets not investigated as much.
Yes, no, definitely.
Which is hard. So tell me, so we've got heaps of questions here, which I'll start kind of going through, but one of them that I've had quite a few again and again is, what are your thoughts on fibroids? And I know you sort of deal with fibroids a lot. When they should be removed, when they shouldn't, because people get told, oh, they're fine. And obviously there's some types that are and aren't. What are your sort of thoughts on that?
So I suppose the first thing is a fibroid is just a benign growth of one of the muscle cells in the uterus. And when I say benign, the chances that it's nasty is less than 0.5%. So we wouldn't go removing a fibroid to exclude something nasty unless the ultrasound thought it was a bit
something sinister.
Suspicious, fibroids largely broken down into, there are those that are on the outside or subserosal fibroids, intramural fibroids, which are just within the muscle of the uterus itself, and then there's the submucosal fibroids, which really push into the endometrial cavity. The guidelines or the evidence is fairly clear that subserosal fibroids don't impact fertility, and so the only times where we would remove them is if they were very large and causing pressure symptoms, so like the woman wanted them removed for other reasons. Or sometimes if they're persistently making it hard to get to an ovary, then you might consider it at that stage, but that's not common. With intramural fibroids, so within the muscle of the uterus itself, we think that a reduction in fertility and an increase in miscarriage, we think the live birth rate is reduced by about 30%.
Right, that's quite a lot.
The problem with it is that the evidence for removal is really poor, and it's a big procedure.
Right.
So I think if someone's had reasonably good quality embryos back and not pregnant, or they've miscarried normal embryos, and particularly if the fibroid is, say, greater than 4 centimetres, then you'd probably consider it.
Yeah, okay.
The ones that are important to remove are the ones that push into the cavity, so the submucosal fibroids, and they are thought to reduce the live birth rate by about 70%.
Yeah, right.
And the evidence is fairly clear-cut that if there's a submucosal fibroid, it should come out.
Yeah.
And the other thing about it is that with submucosal fibroids, it's not a big
It's an
open
easier
procedure.
removal. Yeah.
So it's a hysteroscopic procedure, so it's done through the cervix, and so the recovery is a lot sort of faster.
Yeah.
So without any doubt, they're the ones that I think it's pretty black and white. They should be removed. The intramural ones, you need to sort of consider it. And because the other thing is, it's a big procedure to get an intramural fibroid out. You put a scar on the uterus. There's a period of recovery. You can't fall pregnant for 3 months. So it's not a quick and easy thing.
Yeah. When the uterus has been cut, you've got to be careful.
Yeah.
And what about, this is totally, well, it's not off topic, but it wasn't one of the questions.
Right.
People with like a C-section defect,
Yep.
for example, what do you think the impact of that is on future fertility?
Yeah.
Like, should that be corrected? And
Yeah. So I think cesarean section scar niche is often what it's sort of referred to. And so essentially what happens is it's like a little bit like a shelf that's in the uterus. So when the menstrual blood sort of comes out, it sort of collects in there.
Pools a bit.
And so how women present is they'll often present with some spotting or bleeding after the period. And when someone's doing an embryo transfer and they're having ultrasounds, they'll often sort of say that there's some fluid that's tracking back into the uterine cavity.
Yes.
So I think if there's fluid in the uterine cavity, then that's usually my indication to sort of do something about it. The evidence on all of this stuff is really sort of quite poor. I must admit, I tend to try and repair them hysteroscopically as opposed to doing it.
Yeah, okay.
And again, it's largely just because of the time that's sort of required.
Yeah, because you have to wait 3 to 6 months afterwards, right? If it's not.
Yeah, whereas with hysteroscopic, they can really probably go on and try the next month.
Yeah.
So it's certainly, and ultrasound is just getting better, so they're seeing them a lot more. So just the fact that someone has a niche doesn't necessarily mean anything.
Yes.
It's more, is fluid sort of pooling back into the uterine cavity, and will that stop an embryo from implanting?
Yeah. Ultrasound's amazing now, right? Like when I had my kids like ages ago, like literally it was like, oh, cute. But it was like, it's like someone spilt coffee on a newspaper.
Yes.
And like, no offense if my kids are watching, but like that's what they look like. And like, oh, amazing. And now at like 12 weeks, you're like, oh, it's like, there's something going on, which is crazy. Okay. So what would say, these are questions from people, so thanks everyone for popping them in. What is your advice on eggs that are immature for fertilization? Like, so why is that happening, maybe, is probably the actual question.
Yep. So I suppose in a standard IVF cycle, we hope to get an egg out of any follicle that's more than 14 millimeters, is a bit of a rough rule of thumb. And you will get some eggs that are mature and some that aren't. But in the situation where a lot of them are immature, then the sorts of things you need to look at is obviously the stimulation, and was there some big discordant, follicle size growth and things like that. So, there's some really big follicles and some really small.
Yeah.
And so to try and correct that, you need to look at trying to sort of modify the cycle so that they're a bit more even.
Yeah.
Sometimes there might be sort of quite low LH throughout the cycle, so that's one of the other pituitary hormones that's important for egg development and maturation. Finally, in terms of the vast majority of us will use what we call an ovidrel trigger, which is a HC or pregnancy hormone trigger. So sometimes we end up in a situation where we use a double dose of it. Or there is a couple of other types of triggers where sometimes we use more than one trigger at the same time. And then eventually sometimes you also can, like we give our trigger and then we do our egg collection 36 hours later. So in some situations where we really struggle with getting mature eggs, then you can actually extend the period. So you might give them like 38 hours or something like that. In the case where you do all of those sorts of things and you really can't work out, then that's potentially a reason for doing IVM. But as what came up at the most recent Fertility Society conference, IVM is not good for immature eggs collected at IVF.
Yes, yeah, and the IVM, which we've got Professor Ledger coming on to chat about soon, because he's doing lots of stuff on that, is I believe, correct me if I'm wrong, younger women with lots of eggs.
Yeah, so
almost more polycystic,
correct.
kind of.
Exactly.
Yeah, so it's not for older women who are getting immature eggs.
Correct. Yeah.
Is the relationship between older women and immature eggs because, there's just not as many good quality eggs there, or again, a lot of it is to do with the cycle, the trigger, the timing?
So I think a lot of it. So one of the issues is that if you're if you've got an older woman, you're often using a high dose of FSH.
Yeah.
And so if you're using a higher dose of FSH, what you often find is you get some rapid growth of a couple of follicles and then some others that sort of drag behind.
Yeah, okay. So you might lose a couple of those, you end up collecting.
Yeah, and so it's this whole thing where, so we hope you get an egg over 14 millimetres, and we know that anything over 22 is often either isn't an egg or the quality's poor. So you've got this sort of fine window, and ideally you want them clumped together.
Yeah. And
so often, for instance, sometimes it's about either choosing a different cycle type. So a longer protocol gives you a bit more synchronization of follicles. Or sometimes you may just be, your FSH dose may be too high, so you may actually need to drop down.
It's actually shutting it down a bit.
And because, as I said, it's not so much pure numbers, it's about the quality of what you get.
Yeah. And what about your thoughts on using growth hormone or Sizin for that? Is that something you use, or is it not really? Or is that not its application?
so it's not so much for maturity, it's more in regards to quality.
Yeah. But it helps you get the little ones that aren't.
So the trials on it sort of demonstrated not really an increase in numbers, but some of the smaller trials suggested an improvement in live birth.
Yeah.
There was a trial that was presented but not yet published out of Adelaide, which was quite large compared to all the others that didn't show any difference. The problem is it's quite expensive. Yeah,
I was going to say that's why everyone asks about it. So it's always you're going to spend $1,000 or whatever is on there.
So it sort of adds. So it's to me, it's not so much the immature ones. It's often the ones where you've got poor egg quality. And
you might have a few.
You've excluded endo. You've done all the other sorts of things to try and then it's a bit well, look, you can try it and it works or not. I must admit, and again, we were talking earlier, you'll get some people that will fall pregnant and they'll think that's the best thing.
Yes.
But sadly, there's also a lot of people that use it where there's really no difference.
Yeah. And it's so hard with all these things because, when we sort of the small trial didn't show evidence and things, as I often say to people, the whole thing, no offense to IVF, but you didn't invent it, but is it doesn't have a great success rate in and of itself. So in one way, not the whole thing's not proven, but I guess it's trying to kind of put the things together to optimize that particular person, isn't it? It's quite hard to have something that's going to work for everybody. Otherwise, IVF success rates would be 80 and 90% instead of.
And unfortunately, sometimes it's a matter of being lucky and collecting the good egg. Yeah.
That's what I say to everybody. All the diet stuff, all the lifestyle stuff. We're optimizing what you've got and giving you some tools and things that can help. But it's also not 100% up to you.
Yeah.
It's part of it is, I guess, your doctor, the medication, the way your body responds, and then just what you've got there.
Correct. Yeah.
Some people's hair grows fast and some people's hair grows slow, and you can use a special shampoo which might help a bit, but that it's still like that at the end of the day, right?
So it's actually probably one of the best things that came out of the Alonva trial. So Alonva's a long-acting FSH, so it's one injection lasts for 7 days. So they did a whole lot of trials to sort of say that it was just as effective as the daily dosing, which is what we predominantly use. And they had quite a few people where they did more than one cycle. And they basically compared outcomes between the two cycles. And the thing about Alonva is you can't change the dose.
Yeah.
So it's a fixed dose. They're all on a protocol, so they're all triggered at the same time. They're all experienced people doing egg collections. And they were able to sort of show that more than 30% of people experienced 3 or more egg difference from one cycle to another. So that's just pure...
nothing changing.
Variation in biology from one cycle to another. So that's not someone tweaking this or tweaking that.
Yeah.
It's just, unfortunately, the way it is. And you do see it. You have some people that have a cracker of a cycle 1 month, and then an absolute disaster the next. And it's incredibly frustrating.
Yeah. I often say to people, and I always have terrible analogies. Everybody knows that, but it's like an athlete in a race or whatever. You can get the world record, and then you can not make the semis, but you've still got you and you're you. But not every single cycle is going to be perfect.
Correct.
And I always say, and I assume the IVF doctors probably hate this, particularly in private, that your first cycle you have to think of like a test cycle, right? Because then you attach less emphasis onto it, and like you said, I always talk about it being diagnostic. So let them work out what it is, work out what drugs work for you or don't work for you, but that's not a reflection on the doctor or you. It's like any medication. You could try an antidepressant and you feel terrible. You could try it, you feel amazing, but a bit of tweaking
Yes. Yeah. No.
they get the right thing. So yeah, I was thinking private though. Nobody wants to think it's a test cycle because it's quite expensive. Okay, trying to conceive with PCOS and periods 5 months apart. Treatments.
Yeah. So obviously with periods 5 months apart, then the chance of spontaneous conception is really low. So I think it's really important to make sure that it definitely is PCOS. So part of the diagnostic criteria is there are a few other conditions to exclude. It's also important not just to focus on the female. We need to make sure that the semen analysis is completely fine. And then really it's like still first line is in many cases like lifestyle. So making sure that someone's in a healthy BMI range and things like that. And so sometimes if someone is overweight or obese, even just a little bit of weight reduction will get them from ovulating to not ovulating. And then really then most of us are then sort of moving on to ovulation induction and the most common one that's used is letrozole.
Yep.
I must admit in my lean PCO women, I still offer metformin.
Yep.
That's gone in and out of the guidelines over the years. I suppose the good thing about metformin is that because we're not stimulating the ovaries, you don't need to then monitor a cycle. And particularly if someone is getting some kind of semi-regular bleed, you'll often find that it will just bring it into a more regular fashion and often they'll just go on and achieve a pregnancy. You need to have someone that's relatively patient though, so you need to have someone that if they try it for 3 to 6 months and it doesn't work, that they're not going to be upset. And the other thing is some people don't like the gastrointestinal side effects.
Yeah.
But otherwise, if people don't want that or it's not appropriate, then it's going to be letrozole, which is an oral ovulation induction agent. And we would do that with monitoring. And as I said, we would get 80% of women ovulating. And if you look at the oral ovulation induction agents, depending on the age of the person and things like that, you'll get about 60% of people sort of pregnant within about 4 months.
Yeah. And it's interesting because a lot of people actually don't know about this. So people, come to me going like, I've been trying for a couple of years, I'm only getting 3 or 4 periods a year or something. So they already feel like they're really far into their fertility journey when they're kind of only 3 or 4 cycles in a way. But they're at that mental kind of like fatigue. And letrozole, you're taking it for like 5 or so days, a tablet at the beginning of the cycle. And the monitoring is just some bloods and ultrasounds. So if that's you, like absolutely speak to somebody because there is lots that you can get help with. Okay. So do you have any advice for those who've suffered changes in their cycle due to COVID infection? And I guess sort of maybe even leading on from that, because it's probably a bit harder. Most people seem to, I think, go back within a couple of cycles. Yes. But would you say they need to wait after COVID infection? Because I guess we're knowing from some of the research that COVID can affect sperms. Sperm's not tested all the time. Should they wait a bit after?
Yeah, so certainly the trials in terms of COVID and COVID vaccination and cycles is that it is very temporary. So it is meant to be only by a couple of days and it's not meant to be long lasting. So certainly if someone is like a few months down and their cycles are all over the place, you'd work that person up as if you would anyone with an peri-ovulatory problem. In terms of how long you should wait after COVID to achieve a pregnancy, so again, I think society's moving on and we're learning to live with it. And I think one of the problems is from the time that sperm starts to be produced to the time that's released is about 70 days. Yeah. And so any viral illness, be it COVID, and
I was going to say, would it be the same as RSV, influenza,
or anything like that? Then you will get some negative sort of impact. Yeah. So. Sure, look, if you've got someone who's young and hasn't been trying for very long and things like that, then waiting a little bit of time probably isn't going to hurt them. Whereas, if you've got someone who has been trying for a while or is older, then making them sit on the sidelines for 3 months is probably
a bit overkill.
A bit overkill. Yeah. And so certainly if someone has COVID, we wouldn't go doing an embryo transfer. Yeah. But certainly if someone's had COVID and we basically say, well, take this month out, we're allowing them to cycle on the next month for an embryo transfer. Yep. Not an egg collection because there's some anaesthetic issues there. Oh, right, okay. But from an embryo transfer perspective, we're happy.
Yeah, yeah. And I would say, like, if either of you have been, like, really sick, like in bed, fever, flu, whatever it kind of is, you're probably better off waiting a month for an IVF cycle. You might still try naturally and, roll the dice, but... you're going to put all your money and time into IVF and a month doesn't matter, you
correct.
could push it out a month. But yes, if it did, yes. Dr. Anthony, hi. I'd like, it's like, I'm like, dear Dolly Doctor, I'd like to know what your thoughts are on endometrial hyperplasia and fertility outcomes.
Yeah. So essentially with endometrial hyperplasia, so the endometrium is really, really sort of dynamic. So
it's the lining of the uterus, right?
Yeah, the lining of the uterus. So basically after a period, the lining proliferates. That's what we call the proliferative phase. And it's where the lining just gets progressively thicker and thicker and thicker. And then essentially what happens is at ovulation, the lining then gets exposed to progesterone and it goes from that proliferative phase to a secretory phase. And that's where it sort of secretes a whole lot of substances to hopefully support a pregnancy. And then if you're not pregnant, the lining is shed. So it's a very well orchestrated sort of, process. And with endometrial hyperplasia, essentially what happens is you just get disordered sort of proliferation. So it's usually seen in women who don't have a regular cycle.
Yep.
And so you just get this
the lining just keeps building up and getting thicker.
And the cells start to sort of look a little bit abnormal. And essentially you have, on one end you have normal lining, at the other end you have cancer of the lining of the uterus, and in the middle you have this thing called hyperplasia, and the pathologists talk about either it's either got atypical cells or doesn't. So if someone's got endometrial hyperplasia, it's important that it's treated not just for fertility reasons but for the well-being of the woman.
Yeah.
The other thing is, if there is hyperplasia, because the lining is disordered, it's very unlikely that a embryo will implant.
Yeah. Too thick, doesn't have the right.
So essentially, what needs to then happen is it's usually treated with progesterone, and most of us would put a marina in. So that's a little plastic device that releases progesterone, and then most of us would suggest resampling 4 to 6 months later.
Yeah.
And then only once it's normal, would we then sort of consider putting an embryo back?
Yeah, okay, yeah. And so what sort of symptoms might they get? Like, how would they know they have had it or they've got it?
Most of the time they
won't. In a lining,
yeah, so most of the time they won't. It's usually someone with an irregular cycle, and they have an ultrasound, and the ultrasound says that the lining is thickened.
Yeah.
Sometimes they may say there's little cystic spaces, and that's what prompts an endometrial biopsy.
Yeah, so just seeing an ultrasound would be like, I had no idea that they had that.
Correct.
Yeah. Okay. We did that one. Thin lining. What do you think, or what would you consider about a thin lining?
Yeah. So if you look at the papers, they basically sort of say that a lining between the lower limit's usually somewhere between 6 or 7, and the upper limit of 14. So if you have a lining in between those, then that's optimal, and outside of that is not.
Thick and thin.
Yeah. With the thin lining, I think it really sort of boils down to those people that have actually had procedures inside their uterus and those that don't.
Yeah.
So if someone's, for instance, they've had a curette or they've had some polyps or fibroids or whatever sort of removed, then I think it's really important that you have a look inside and make sure that there's no scar tissue, and if there is scar tissue, you try to divide it and
remove as much as possible. And so that's in a hysteroscopy, right?
Correct.
So, yeah.
Whereas in someone who has never had anything inside their uterus, the question is whether or not it is just normal for them.
Right. Yeah.
Okay. And so there will be some people that will have a thin lining where that's them.
Yeah.
Okay. And it doesn't really mean anything.
And so could put an embryo back in and it gets thicker. It's just theirs is thinner to start with,
Correct.
or it's never going to thicken.
So some they'll never thicken.
Yeah.
Yeah.
But still be able to maintain a pregnancy or not?
Yeah. Often when there's no history of anything, often it'll be fine. From a treatment perspective, the treatment is either giving estrogen to sort of thicken it up, because that's what sort of thickens it up. So you can do that a few ways. So one is you can either do a cycle where they're taking estrogen tablets and patches and various other ways, or you can do a cycle like we would with an IVF cycle where we'll try and grow multiple follicles, and then that way the person's producing a lot of their own.
Yeah.
And so that's one way is you give a lot of estrogen to try and thicken it up. The other way is to try and improve endometrial blood flow. So, for instance, that's where things like, like potentially vitamin E, aspirin, Viagra, and all that sort of stuff plays a role.
Do you still use Viagra?
I don't.
Yeah.
No, so,
you don't see it much anymore.
No.
For those of you who was a bit of a Viagra tablet up vaginally to stimulate blood flow, but it seemed to kind of be more 10 years ago. It was a bit of a rage.
Yeah, so I use the vitamin E and I use low dose aspirin.
Yeah.
And again, you can't measure the success of that really in terms of, but there are some ultrasound studies that show improved endometrial blood flow.
Yeah.
In some people...
So improved blood flow, but maybe not a thicker lining, but enough blood flow for implantation. You feel comfortable doing a transfer.
Yeah. And so then the other thing is, like, sometimes it doesn't matter what you do, the lining just remains thin. And so what I've often done in that, and ultimately you have to do a transfer at some stage, okay? Yeah. And so what I'll often do there is I'll do the cycle that I think is going to be best for the person, but as opposed to putting an embryo back, I might do a gentle biopsy and ask the pathologist to say, is this lining adequate?
Right.
Okay, so they'll sit there and if they say, look, this is a normal luteal phase lining, then I'll just say to the patient, look,
next cycle we're happy to put it back.
Let's just do it. And to be honest with you...
And so would you be like, if you'd be like, well, hang on a second, that lining doesn't look good, it wasn't expected, we're not going to do a fresh transfer, I prefer to do a biopsy first, or in their first one you might, well, I guess...
So it depends on the...
How many embryos you've got.
How many embryos, and said, what's their history in terms of have they had procedures and things like that. So I think the thin lining, the first thing is, have they had procedures or not?
Yeah. And for those of you who are like, oh my gosh, maybe I've got a thin lining, because everybody asks me that when they're saying they've had implantation failure, I can almost assure you that it is being looked at. It's just normally, I don't want to speak to 100%, but I'd say 99.9, when nobody's told you anything, it means it's normal. Yeah, because a lot of people sort of think, oh, maybe it was thin and that was the issue, but like they would know, right? People...
Correct. And the other thing is, ultrasound is not a perfect science.
Yeah.
And so you've got to know the people who are doing the scans. And people tend to either undermeasure or overmeasure. And so you've got to kind of know where your sonographers kind of sort of sit.
Yeah.
Because it's one of those things where...
Oh, it's hard, right? It's moving, there's different angles. And would you say, like I was having this discussion with a patient the other day, different points of the uterus could actually have slightly different linings, or no?
Well, it's more just like the way in which the uterus is oriented will depend on how full the bladder is and all that sort of stuff. And so sometimes a uterus can just be hard to measure.
Yeah.
And so, if you've got something that's hard to measure and you've got someone that's sort of struggling, we see variations.
And obviously, like, a uterus is actually a lot tinier than what I think we think. We're like, well, here's the uterus, here's the ovaries, type of thing. It's all very small. But if, say, for example, they had a fibroid removed or something on, when I say one side, makes it sound bigger, and a thin lining, is it possible that, like, actually the other sort of side, so to speak, might actually have a more proliferative or thicker lining, or is that... all a bit simple.
So I suppose in that situation there, like if someone's had something done,
like to the right,
done on one aspect of the uterus, I suppose if implantation does occur, because it's a bit random, like we can't control that. I suppose you would want it to occur on the side that hasn't, because I suppose.
It may be
the other issue is the other placental abnormalities throughout the pregnancy, like where there's an abnormally adherent placenta and things like that.
Yeah. So you can sort of like direction it to the other aspect, but it's going to implant where it implants,
where
right?
It wants it, exactly.
Okay. Bit of a simplistic question from me, but hey, we talk about these things in clinic all the time. Okay. I already asked you that one. Where did this next one go? Okay. Thin line. I'm fairly confident I have endometriosis. Would a laparoscopy help me get pregnant? I think we sort of talked about that, didn't we? So, like, laparoscopy, you'd say, actually increases their chance of natural conception, in addition to IVF.
Yes. Well, most of the data is with natural conception.
Yeah.
And we think it probably halves the rate of natural conception.
Yeah.
So certainly, if someone's got the classic symptoms or something on ultrasound and things like that, and particularly if the semen analysis is normal and all that sort of stuff, then a laparoscopy is worth discussing.
Yeah. And what about the stages of endo? So, so I think a lot of us know that, stage 1, you could be riddled with pain, but it's not very deep, and stage 4 could be silent with no pain and it's everywhere and everything's stuck together. Does the stage affect the fertility, would you say?
Interestingly, most of the larger trials looking at endometriosis and fertility where there's decent evidence is actually in the more mild to moderate sort of endometriosis as opposed to the really severe. The ones that are difficult, for instance, are if you've got someone with severe endometriosis with bowel involvement and things like that. That's kind of difficult because you're going to be subjecting the person to a really big procedure with some significant risks. So obviously if someone's got lots of pain symptoms or, I don't know, bleeding rectally or something like that, then there may be other reasons why they are just going to have their surgery.
Yeah.
But
it's a bit more clear cut if you've got terrible pain, because there's a net benefit in that you might get less pain. It's the sort of borderline ones that are harder to maybe...
And so often what you do with the really severe ones where they don't have pain and things like that, or they're not prepared to go through that surgery, you might sit down and say, well, look, let's try a cycle of IVF, and we either are going to get you there quickly, or if not, then we know what the next step is. And if you get those people, even with severe endometriosis, if you get them pregnant, it's very rare for the endometriosis to actually cause problems within the pregnancy. So they don't need to be worried that there's going to be all these issues in the pregnancy.
And I think a lot of people also think that like, oh, my pain's not like that bad kind of thing. It's like it takes some Nurofen or Naprogesic and it kind of like is manageable. That's sort of like normal. So I think a lot of women, even though there's a lot more, I guess, talk about endometriosis now, still kind of think it's like only the people who are vomiting and lying on the floor of the bathroom can't go to work. They're the ones with the issues, but that's not really the case.
Correct. Exactly.
So if you do have a period pain, like absolutely make sure that you do speak to a specialist about it, because sometimes you don't even need to do IVF. It may just be you have a laparoscopy. Obviously, it's not the right thing for everybody. And the other thing that I find, and I don't know if you see this at all in your clinic, is that when people have been seeing people like me, and there's amazing acupuncturists and things like that, and we can do so much to manage endometriosis. So if you weren't trying to conceive, for example, I've had people booked for surgery that don't get it because they're fine at that moment. However, us getting the pain pathways under control doesn't mean that you don't have endometriosis there affecting your egg quality and your ability to conceive. And I think that's something that, I don't know how much you sort of see this in your practice where, it was really painful, but I've been doing X, Y, Z and now it's a lot better. I say to them that's awesome. That's great. But there's still that impact.
Yeah. So there definitely is. And so I think that's where, I think that's where it's really important to have that ongoing communication with patients as they're going through their treatment. So I'll often be sort of saying to people, well, if you go down IVF, that's completely fine, but if you're not getting pregnant quickly, we need to reconsider.
Look at what else to do. Yeah, but just because it's under control doesn't mean that the effect of
fertility
the endometriosis on the eggs and the quality isn't still being affected. Because we can take a lot of the inflammation and pain out, but we can't remove the endometriosis with fish oils, even though that'd be cool. We'll put you out of a operating job. So, it'd be great if that happened, but I'm sure you would prefer people were comfortable. Okay. We've been through that one. Let me just check if we've got any questions on here. Oh, okay. All right. How to regain cycle while breastfeeding for number 2. Anything will help with ovulation. I mean, I had a patient with this today. You kind of either have to choose that you're stopping breastfeeding or not, right? We can't really make you ovulate while you're breastfeeding. Would you use letrozole or anything breastfeeding?
No, not usually.
It's a bit clunky.
Yeah. So look. I normally try and get people to sort of some people get people to stop breastfeeding altogether. What I usually do is I'm normally happy if people are feeding once in the morning, once at night. Yeah. They have a regular cycle and their prolactin level is normal.
Yeah. Is this for IVF though?
For putting an embryo back.
Yeah. But if they're just trying to help ovulation.
If they're just trying, you need to get the...
Yeah, you're not going to get an ovulation induction medicine. You need to just... And it's really hard because a lot of my patients are like, I don't want to focus on the next baby that might not come.
Yes.
For this baby. But, sometimes, a lot of people are racing against the clock. Okay, risks of a 2-vessel cord in pregnancy with no other issues.
Yeah. So historically, people were concerned about 2-vessel cord and a high rate of chromosomal error in the pregnancies. Because of the sensitivity of our first trimester screening, that's a little bit less of an issue. And so the only issue beyond that is growth restriction in the pregnancy. So it's been a little while since I've done obstetrics, but essentially if you had someone with a 2-vessel cord, you'd normally just do some additional ultrasounds and make sure that the baby's growing appropriately.
Yeah, and most people do an IPT as well to sort of double check kind of thing. Yeah. Anything different stressful though, isn't it? I think that's the thing. Okay. Is there hope for women with post-menopause FSH levels and low estrogen? So high FSH and low estrogen, is there hope?
So, look, I think where that's difficult is, I suppose it's whether or not the menopause is early or premature, or whether or not it's menopause that's occurred at a
young
normal
age. Yeah.
So, if you've got someone with premature ovarian insufficiency, their chances of pregnancy are not zero. Their chances of pregnancy, it's not high, but it is probably around about sort of 5%. And funnily enough, it's actually higher if they're on hormone replacement therapy as opposed to not.
Right.
And again, depending on the clinical situation, if the person wants to, I'll often sort of see if we can stimulate something. And for some people, they understand the fact that the likelihood that that's going to result in anything is very low. But for a lot of them, it's about giving it a go, not having regrets. And then potentially sort of considering donor eggs, sort of moving forward and things like that.
Yeah.
If we're talking about menopause at a normal sort of age, and so the average age of menopause is about 50, the normal range is 45 to 55. Look, that's really hard because not only are we talking about a really decline in egg numbers, but it's also associated with very much a decline in whatever eggs are there is a quality. And so probably IVF is probably not going to help in that situation. Sure, there's always going to be a chance of sort of pregnancy naturally, but it's low. And so in that situation there, again, it's about sort of making sure that people don't have regrets and they've tried everything within reason. Like you don't want to exploit a patient, but just trying things so that they are happy with what they've done, and then going through what the various other options are in terms of things like donor eggs and that.
Yeah. And so that would, like, in terms of, a lot of, I guess, my patients with similar questions are more sort of early 40s where they actually are still cycling, but maybe they're not obviously post-menopause sort of FSH levels, but maybe they're 25, 35 type of thing, but they're still sort of cycling. Yeah. Would you say that that's just a reflection of egg quality being really low and them sort of coming towards the end? But again, if they want to explore it and have a crack, do it, but don't be recommending 10 cycles.
Correct, exactly. And I think it's one of those things that any sort of treatment, I think it's just important of having the conversation at the end of each treatment cycle.
Yeah,
which we love. And it becomes very clear, like, if we do 2 cycles and we can't get eggs, or embryo development's so poor that we don't have embryos to transfer, then...
It's almost I always think it's almost a good bad situation because it gets called for you, which is terrible. But, I think those women who, are 44, 45 and actually do get 5 or 6 eggs that sort of don't really make it to the end, or one does, they're probably a little bit polycystic or multifollicular, even if they're not PCOS-y. It's much more difficult, right? Because there's this kind of almost gamble, but one of those could be it.
Could be okay, yes.
It doesn't get called for you. You have to just kind of call it yourself.
Yeah.
Okay. All right. Let's see what else we've got here. I have time for a couple more questions. Okay. Recurrent miscarriage times 3. How do we increase the chance of success for an FET? They've got 1 normal embryo left.
Yeah. So I'm assuming that's 3 normal embryos back.
Do we know who's asked that? That is question from we don't know who's asked that. Sorry.
Okay. So look, I think the definition, like the older definition of recurrent pregnancy loss has been 3 losses. It affects 1% of couples, and you can identify a cause in about half to 2/3. Most international guidelines...
only affects 1% of couples?
3.
It's just...
3 losses,
Which is all of our patients.
That's right.
We don't see the other 99. Yeah,
that's right. So... most of the newer guidelines are saying that we should offer investigations up to 2. Yeah. You test about sort of 5% of couples and you uncover a cause in just under 50%. So it's really important to make sure that both have normal karyotypes, from a male, that sperm DNA fragmentation is normal. The female should have a really good quality ultrasound, and hopefully it's like a sonohistogram to make sure that the uterine cavity is normal. And then there's a whole barrage of bloods that gets done. So there's all the clotting profile, some immune blood tests, endocrine profile, particularly thyroid and things like that. And so a lot of it is just basically making sure that that is all sort of completely sort of normal. And this opens Pandora's box, but then there's a collection of investigations where the evidence for it is not great. And that's like, is there, for instance, like an altered immune profile inside the uterus and things like that. There's no doubt that in some women it's probably relevant. And we'll talk about this earlier where I sort of said it's probably a test that's sort of overdone. The evidence for the testing is not great, and unfortunately there's very little evidence for the treatment. The treatment is largely sort of safe, but there are small increase in risks of some things. And so it's often about having a bit of a lengthy discussion with who's managing you in regards to, well, what are some of these tests? What are the pros and cons of it? And then the two of you making a decision in terms of whether or not you're prepared to go down that path or not.
Yeah. And just quickly, because we're at the end-ish and it is a big conversation, you were sort of mentioning that you prefer, if that investigation sort of is being done, to be looking at the immune system via biopsy as opposed to bloods, looking at NK cells and Treg cells in that sense. So for that particular person who's had the 3 and we've got 1 left, would you sort of be thinking definitely hysteroscopy with a biopsy?
Correct, yeah.
At that time? Yeah. And even things like some people haven't done a hysteroscopy, which, there can be, I mean, if you want to go for procedures you don't need, but endometriosis, where, you just need a course of antibiotics and we'll do some probiotics afterwards and mop you up. But, it's amazing how I had a beautiful patient that I spoke to today who's had 2 babies, and the second one, IVF cycles and so much kind of difficulty, and eventually sort of got that antibiotics pregnant the next month.
Correct, yes, exactly.
So I mean it's hard, right? Because you don't want to do lots of things before you need to, but like IVF's a big thing too. Correct, so do you routinely do a hysteroscopy before IVF? Or
So I think and again it depends a little bit on.
I mean, obviously, most people don't have endometriosis. It's just you could.
So the risk of doing a hysteroscopy is low. I suppose there is a small, but I suppose there's time and there's
money,
financial component to it. And I think also if you've got a really good quality ultrasound, the yield of a hysteroscopy on everyone would be low. No, it's interesting. Thank you. Okay, we've got one more. Okay, does endometriosis cause recurrent miscarriage and a higher rate of abnormal embryos? We've sort of answered it, but maybe not the miscarriage. Yeah. So in terms of how it affects fertility, so the main reason is via an effect on egg quality. There's no doubt that if someone has really bad endo, it can sort of damage the tube, so there can be an anatomical component to it. In regards to sort of implantation, again, there's some studies that are suggesting yes, other studies that are suggesting not. But from a miscarriage perspective, I think most of us think that the role of endometriosis is pretty small. And so, for instance, a laparoscopy for endo doesn't make it into any of the international guidelines on pregnancy loss. So it's not really sort of something that we sort of go sort of down the sort of path of. I suppose the only sort of exception to that is that endometriosis and adenomyosis are fairly sort of closely sort of linked. So adenomyosis is where the lining of the womb or the endometrium is present within the muscle of the uterus. And so if someone's got a really what we call an adenomyotic uterus, then that may have a role. But endometriosis per se should not really be cause of recurrent pregnancy loss.
No, and maybe though it's more of the association, would you say? So we know that endometriosis is associated with an imbalance in gut bacteria. We know lactobacilli is really important for pregnancy maintenance, implantation, and maybe it's other elements, or it's hard to say. Quickly on adenomyosis, if someone's got mild adenomyosis shown on an ultrasound, is that doom and gloom, or is there hope, or should that be... I mean, it's hard to treat, right, unless you're going to give them Zoladex for a couple of months or something.
So the hardest thing about adenomyosis is the treatment options we have before. So if someone's got mild adenomyosis, again, it's one of these things where you kind of got to look at what treatment they're having. And so again, if it's an IVF patient and and essentially you're sort of putting embryos back. If they're not falling pregnant, it's a matter of sort of saying, well, is this just an embryo issue? So, for instance, are the embryos not of a great quality? So they might be embryos not suitable for testing, and they're a bit borderline, do you freeze and things like that, of which it's probably got nothing to do with anything implantation-wise.
Yeah.
Or are they beautiful embryos that have been tested that should give rise to a live born in 50 to 60%, but they're not getting there? And so in that situation there, that's when you sit there and say, well, that adenomyosis is probably relevant in this person. And so then you would subject them to things like Zoladex or putting a Mirena in for a few months or some other sort of treatments to try and see if you can dampen it down.
Yeah. And do you think like the Mirena is, I mean, obviously you've got to put it in, which some people don't like, but Zoladex, which is like almost putting you into a fake kind of menopause for a little drop all the estrogen out of you, it makes you feel menopausal.
Yes.
Do you seem to prefer the Mirena because you don't get all those side effects, even though it's a bit more invasive, I guess, or it depends on the person?
I think it depends on it. So, and so for instance, if you got someone who's like got it, because we're often talking about the ones with really bad adenomyosis.
Yeah.
And so often in those, you're often trying to tackle it via a few different ways.
Yes, okay.
So it's often Zoladex plus a lot of progesterone as well.
Yeah. And what about PRP for that? Well, platelet-rich plasma, or is that sort of another just off the side one?
I'm not sure of anything in regards to PRP and adenomyosis. Obviously, there's lots of stuff about PRP and the thin endometrium or Asherman's and things like that, but I'm not sure about. I haven't read anything about it in adenomyosis.
Maybe it's a bit experimental, but a couple of, thank you so much. Like your brain is amazing, particularly at this for this time at night. So thank you for staying back and sharing everything with us. I think you guys will agree. Anthony Marren is an amazing fertility doctor, person, and doctor. Like he said, you're probably super busy. I don't know, but like I'm sure you are. But that quality of care and follow up and getting to understand what happened in that cycle, I think, particularly with Google and things like this, people are really informed and they actually want to be a part of it, which I always say probably is a bit annoying for doctors sometimes. We used to just walk in and go, these are my symptoms, what do I do? And now we all come in with, Google Scholar. I mean, I do it, poor doctor, evidence on, but I saw this trial that and so it must make it hard, but it's just the way that it is that people want to be more informed.
I suppose the thing is it forces us to keep up to date.
Yeah, okay, well there you go. So that's a good thing as well. Yeah, awesome. Thank you so much, guys. For those of you who've joined us live, thank you so much. And hopefully we've answered all of your questions, and then we'll pop this into the Instagram or IGTV, and you can watch it back later. So thank you so much for joining us, and thank you for so much for your time.
Thank you very much for asking me.
Pleasure. Thanks everyone.
Thank you.
Bye.
Bye.